idiopathic and secondary maybe because of the multiple disorders like lymphoproliferative disorder or connective tissue disorders or RPGN, etc. There are multiple things. I will not go in detail of that. Then the cold type, the cold agglutinin syndrome, it may be primary, secondary, and PCH is paroxysmal cold hemoglobinuria, commonly in children. It's again, it's a primary and secondary, maybe because of infections also secondary. It can be a mixed type. It's a much rare than a mixed type, only 7 to 8% contribution of mixed type. And there is a drug-induced autoantibody, mainly misdiagnosed or mainly underdiagnosed. It is always as a drug-induced autoantibody, and 1 to 2% or 2 to 4% will be contributed by that negative AIHA. The common clinical findings and laboratory markers in AIHA are like clinical findings. You will see a fatigue, jaundice, dyspnea, dark urine because of hemolysis, and other signs like infections, organomegaly, rashes, arthralgia, etc. You will get. But fatigue, jaundice, and dyspnea are the common things we see in clinically. In laboratory, you can see a hemoglobin. There is a decrease or a much decrease in hemoglobin. Then the reticulocyte, it may be decrease or maybe increase. It is sometimes it's very much increased. Schistocytes are towards normal range. LDH, it is slightly increased or increased. Haptoglobin, it's very reduced. And bilirubin is increased. Ferritin may be normal, may be increased. Platelets are towards the normal side or may reduced. WBCs are normal side. Hemosideриnuria, it may be normal or it may be sometimes it is increased. These are the laboratory markers we see in AIHA. Why we are interested in AIHA? It creates a problem in our blood banking. It masks concomitant presence of clinically significant allo-antibodies. There is a warm autoantibody in a patient serum. It reacts generally with all the RBCs we test. We do antibody screen, we do antibody identification, we do cross matches. They react with all the cells. Thus, it marks the presence of potentially hemolytic allo-antibodies. It's identifying this allo-antibodies are important to avoid the hemolytic transfusion reactions. But this masking will create a problem to us. Resolving these cases are always tedious and time-consuming. And this autoantibodies react with all donor cells, and it may, because of this, the compatible blood is almost always impossible. It always create a problem. Now, coming to a case for the today, is a 22-year-old female admitted to the emergency room, presented to emergency room with palpitation, asthenia, and dyspnea. Her vital signs were normal, except for tachycardia was there. Chest X-ray was unremarkable. ECG was normal. Blood counts was like this, like hemoglobin was only 3.9. MCV was increased. It was 107. There was leukocytes and platelets were normal. LDH was 1.5 times for the upper normal limit. Reticulocytes was normally increased to 50, while bilirubin was increased for 3.1. Vitamins and iron levels were all normal. Differential diagnosis of this anemia in admitted patient actually encompasses a large number of conditions. It's not only AIHA, it's a large number of conditions. An initial workup includes a good clinical history and physical examination. And there are several tests we have to do to investigate all these things. The differential diagnosis includes all the things. Like it may be a vitamin or iron deficiency. It may be an iron, liver or kidney disease. It because of infections or hemoglobinopathies or any cancer or any drugs or autoimmune hematologic diseases. But the point to be noted here is the AIHA should be suspected clinically when there is a macrocytic anemia of various degree and there is a altered hemolytic parameters are there. Like in this case again, LDH was increased. There is increase in conjugated bilirubin. If haptoglobin is decreased and augmented absolute reticulocytes are there. Suspecting AIHA, the clinicians ordered the DAT and the 2 units of blood transfusion as the patient was severe anemic with a hemoglobin of 3.9 only. You can see, and here it is written is gold standard for diagnosis of AIHA is home test or the DAT. It's a gold standard testing for diagnosis of AIHA. We started with immunohematological workup. We started with DAT, the DAT polyspecific. We started with polyspecific. It is anti-IgG or C3 N plus C3D combination. It's a 4 plus. It's 4 plus positive, strong positive DAT was there. We came to blood grouping. The forward, what you say, you can see forward is AB positive, 3 plus, anti-AB 3 plus, while reverse it is clear O with an auto control is 3 plus. It was a grouping discrepancy done on tube technique. But as it was an old patient of the hospital, old registered case, HIS records were checked and it was shown that the blood group was O positive, not AB positive. And auto is also positive. It was clearly indicated that the forward grouping is clear indication that auto antibodies are there. We done the antibody screen also. You can see here it is a pan positivity 3+3+ along with 3+ auto. We done antibody identification also. It was again a pan positivity here. We repeated blood grouping with 3 times of warm saline wash, and we got a proper blood grouping of the patient O positive. While the reverse grouping was still there is a problem with O cell and the auto was 3 positive. Auto was strong positive. AIHA was suspected here. We are moved to a next step of the as polyspecific DAT was positive. We have done the monospecific DAT there, and what we got that IgG was 4+ positive, control was negative, and complement the C3D was negative. Now, what should be there? The laboratory evaluation in AIHA. There's 2 criteria are must for diagnosis of AIHA. There should be a laboratory evidence of hemolysis, which will be indicated by your CBC, by complete blood count, by peripheral smear, the presence of any schistocytes or abnormal cells, your reticulocyte count, the increased bilirubin, increased LDH, decreased haptoglobin, and urine HB. There always should be there serological evidence of antibody, but sometimes you not get a serological evidence like in DAT negative AIHA, but it should be there. Like DAT positive should be there. And supplemental testing, which includes elution, serum antibody screen for presence of autoantibodies, and which IgG type of antibody, which immunoglobulin type of antibody is this? What is the thermal amplitude of that antibody? What is the subclass of that antibody and the titer of that antibody? It can be done. What are the various methods of DAT? See, the common method, the gold standard method is a conventional tube technique. You can see the sensitivity here. When there are around 300 to 500 molecules per red cell, the column, your CTT, the conventional tube technique works very well. But when the cells are very less, like 120 to 180, then the column agglutination technique will help you. Like much more sensitive is ELISA. It's an enzyme-linked antiglobulin test for 80 to 120 molecules per cell. And the most sensitive, the highly sensitive is a flow cytometry. You can even detect 30 to 40 cells per red cell also. But at present, I think so the CAT is in a demand of the day with regards to sensitivity, cost, and ease of the work. Like in India, maximum of the blood banks, I think so they are using CAT and CTT. Coming to what should be the flow of the testing in a DAT evaluation. When your DAT is positive, this IgG and complement is positive, polyspecific is positive, you should proceed to first of all, you should see what is the clinical details, what is any history of transfusion, any pregnancy history, any transplant history, or any drug history is there, along with the laboratory parameters like hemoglobin, hematocrit, all hematological parameters. Is there evidence of the hemolysis? You should proceed to further testing, like go for a monospecific DAT, go for IgG subclasses, go for an elution, like specificity and titer and amplitude. See, till elution, we are dealing with the red cells. We are doing all my workup on the red cells. We are doing monospecific DAT on the red cells. We are doing IgG subclasses on the red cells. We are doing elution on the red cells. ICT, it's on the serum. Auto control, we are checking on the patient's serum, and absorption studies we will do on the serum. The first 3 steps are mainly for the red cells, and last 2 steps are from the serum of the patient. But if there is no evidence of hemolysis, no further investigation unless transfusion is required. If your transfusion required, you have to do all the investigations. If there is no transfusion required, nothing to be done. As a clinically should be managed clinically. Now, what is the importance of this monospecific DAT in this picture? See, this is a picture of, you can see the IgG complement control in first picture. In second picture, you can see even detail is IgG, IgA, IgM, C3C, C3D, and control. See, what is this? They're determining the immunoglobulin coating. There's a coating on this immunoglobulin coating on the RBC. That means positivity means that there is some antibody, in vitro sensitization of the antibody, in vivo sensitization of the red cells. This immunoglobulin coating is help you in classifying the AIHA and its prognosis. When these red cells are coated with multiple immunoglobulins, they activate the complement more effectively, leading to increased hemolysis. Like there are 2, like IgG and complement both are there. More hemolysis will be there. Like IgG, IgM is also there, but IgM, finding IgM in this picture is very rare. But if it is there, 100% the hemolysis will be much more. Complement as antibody. IgM coating is difficult to demonstrate in our lab-based AG test. Why? Its IgM antibody tend to dissociate during washing. And polyspecific IgG, what we use commonly, polyspecific IgG for initial testing of DAT, it contains little, if any, IgM activity. It mainly contains IgG plus complement C3D. 20%, 10 to 20% patients with AIHA may have DAT positive due to complement alone. Like in cold agglutinin syndrome, what is it's a pathogenesis is the IgM autoantibody react at lower temperature. It's a cold temperature. It activates complement. While when come to central circulation, IgM dissociates. Only C3D detected by HG test. It was the red cells are coated only by the complement. That's why we detect in serology we get only positive results by the complement C3D only. You can see multiple results here. IgG is positive in one picture. Second, IgG plus complement is positive. Complement C3D. In the other picture, you see the C3C and C3D both are positive. In last one, you can see IgG, IgM, complement C3D all are positive here. It's a very, if this picture is there in the last slide, this one picture, the patient will present with severe hemolysis. Now, what is the role of this subclass of IgG? The IgG subclass determination helps in prognosis of disease. See, this IgG3 have G1, G2, G3, G4. These are 4 subclasses of IgG. Out of which G3 has a high affinity for mononuclear phagocytes, thus require very few molecules for initiation of phagocytosis, thus have a great potential for hemolysis. It means if you put a test for the IgG subclasses and if you got it at G3, it means there is a high great potential for hemolysis. You should start directly with the second line drug for the first line drug for treatment of AIHA is steroids, and secondly go for a rituximab or multiple other drugs. I think so you should go directly for the rituximab when your IgG3 is coming. It will help you for treating the patients much easily. Now, interpretation of DAT results. You can see here the first line is a polyspecific IgG is positive for all. While when you put monospecific AHG, you will get a multiple picture. Like first picture, you get control should be negative always. IgG is positive, complement is positive. The interpretation you are dealing with warm AIHA or delayed hemolytic transfusion reaction or drug-induced hemolytic anemia. If its only complement is positive and a control should be negative, you are dealing with the cold AIHA. Your anti-IgG is only positive, but both are negative. Control is negative. Control should be negative. Complement is negative. Dealing with warm AIHA. And if it all are negative and your polyspecific AHG is positive, you should repeat with the new lot of AHG. There's a problem with the AHG. If your poly is coming positive, mono should come positive. There is a problem either with the poly or with the mono. You should repeat the test. If your control is also positive, you are unable to report. Coming to our case, what we see is a polyspecific 4+, monospecific IgG was positive, while complement control D was negative and control is negative. It comes towards warm AIHA. Again, it favors warm AIHA. Then we proceed to next step. See, in warm AIHA, what happens? The immunoglobulin is IgG responsible. Maybe sometime IG or IgM, but commonly it is IgG is responsible. In DAT testing, in DCT testing, you will get IgG or complement C3D. Eluate, when you do the elution of these red cells, you will get an IgG picture, and the specificity will be the pan reactive. As it is an auto antibody, it will react with all the cells of your pan. It's a pan reactivity. When you're dealing with the cold agglutinin syndrome, the immunoglobulin responsible is IgM. As IgM dissociate, in DCT you will get only complement C3D only, or C3C or C3D, anything. While eluate, of course, the complement will not come in eluate, it will be non-reactive, and specificity will be more towards capital I, small I, or PR. In PCH, it is actually IgG, immunoglobulin is IgG here. It's a biphasic, which will be diagnosed by DL testing, donor listener testing. I'm not going in detail of donor listener testing here, as we are dealing here with warm AIHA mainly. DAT is again C3D positive. Again, eluate is non-reactive, and specificity is more towards P antigen. While in mix, it's a mixed picture. Of course, the name suggests the mixed picture is IgG, IgM, both are responsible for immunoglobulin type. And the DAT will be IgG plus complement positive. Eluate, of course, IgG will be there, and the specificity again pain reactive. It is mostly towards it's merely same towards the warm AIHA. Now coming to elution, what is elution? Elution frees the antibody from the sensitized cells. It recovers your antibody in a usable form. Elution means a removal of antibody from the sensitized coated cells. See here it is an example. This is in red cells. These are the antibody attached to the red cell. This is called as the sensitized cells or the coated RBCs. This is called sensitized RBC. Now what we do elution and we get an eluate containing antibodies which is in a usable form. So this eluate. Now this eluate, it may carry an autoantibody that reacts with all cells called as a pan reactive, or it may be an allo-antibody, it reacts variably. While when we are dealing with AIHA, we are expecting this autoantibody and it will give a pan reactive picture. After having an eluate with you containing antibody, you can easily identify what's the specificity of this antibody, what is the titer of this antibody, what is the thermal amplitude of this antibody. As you are now antibodies and your usable form with maybe an albumin, with maybe any other solvent. So what are the different methods of elution? Like they are temperature based, lens thinner, modified heat, Louis freeze, ultrasonic, acid elution, cold acid, gitonin acid, glycine acid, and organic solvent, which are these are not rarely used now. Commonly, these both are used, and these are some advantages and disadvantages of different elution techniques like heat. Quick and easy, good for ABO-HDN, while poor for allo and auto. Freeze thaw, again good for ABO-HDN, quick and easy. When you have smaller volume of cells, your freeze thaw technique will help you, and again poor for allo and auto. While cold acid, good for most warm auto and allo, but somewhat false positive. Sometimes it gives you false positive results. Digitonin acid, good for most antibody. It is non-hazardous. But there is a washing of stroma you have to do this, which is time consuming. While methylene chloride, its vapors are harmful. It is good for IgG, auto, and allo. What we do, coming back to our case, we have done the acid elution in our case. There's a kit available directly. We use that kit only, acid elution. You can see the last wash results are okay. But what we got the test is that the eluate was a pan reactive. Clear cut pan reactive, reacting at 8G phase even also favors the warm AIHA. Coming back to our flow chart, what we do, we have done IgG 60 positive. We have seen our patient shows the clinical details. There is a typical history of clinically she is favoring AIHA, while the other laboratory parameters are deranged favoring AIHA. There is a evidence of hemolysis. We have done monospecific DAT. Its IgG is positive, complement is negative, control is negative. We have not done IgG subclass as we are not having that at that time, but we should do for to know the prognosis of the disease. We have done the elution. What we got is a pan reactivity at AHG phase. We got it. Now, what is remaining is ICT. ICT, we have already done antibody screening. It's positive. Auto control is positive already. Now we are left with an absorption study. What is absorption study? We proceed to the absorption study now. But of course, when there is no emergence of illnesses, we should not do anything. Now, coming to absorption study, what is the aim of absorption study? Is in detection of any allo-antibodies, which is in patients with autoantibodies, which is masked by autoantibodies. Our aim is to detect these allo-antibodies. So, what are the various techniques, various methods, various you can say various terms available for detecting these allo-antibodies? See, I have seen multiple centers doing like this. That's why I mentioned here. You can dilute 1:5 dilute autoantibodies to detect allo-antibodies. What they do? They take the serum, they dilute with the saline or the AV plasma, neutral plasma, and they detect allo-antibodies. See, this is unreliable. This should not be done at all. This is as this unreliable will mask allo-antibodies also. These allo-antibodies will also get diluted. But there are centers doing this practice. Please, I say you, please don't do this practice. Least incompatible blood, which is the most commonly, I think, so many of the centers are using this least incompatible best match blood without doing allo-antibody identification is the option, but if again it is unreliable, may you cause you severe STR sometime, but it should be reserved. I don't tell you it should not use, you should use, but it should be done as an emergency basis only. When you have time, you should go for absorption studies. The absorption studies are ideal, but again, these are tedious, labor intensive, and time consuming. Now, coming to an auto adsorption. Here, what is the first the treated autologous cells? What do you mean by treated here? It should be at least enzyme treated or a ZAP treated. Okay, you can use without treated also, but the treated autologous cells will have a good affinity towards the for catching the autoantibody. That's why the treated autologous cells are much preferable for doing autoadsorptions. These are first washed thoroughly to remove unbound antibody. These autologous cells are then incubated with the patient's serum for 1 hour. The cells are the patient's only, and the patient's serum is the same patient only. See, both the things are from the patient. That's why I call it auto adsorption. The cells are from the patient, and the patient is we are using the patient serum also. The both things. The serum is then harvested and incubated with a new batch of autologous cells. When your absorption is complete, when you call your absorption is complete, when there is no reactivity is observed, it is not unusual for 3 to 6 sets of the cells to be used for autoadsorption. Even some powerful warm autoantibodies, the technologies may be unable to remove the autoantibody completely. See, this is a method. See, in the first part, the one part of serum is added to one part of red cells. The serum is there and one part of red cells are there. These red cells are from the patient only. This serum is from the patient only. We have taken these red cells, we have treated with enzyme, we have washed these red cells, and we put the patient serum in this only. We mix this, we have put it for a 30 to 60 minute incubation. The first tube is then spun for 5 minutes, and serum is added to the second tube containing equal part of the fresh lot of red cells. This is a fresh lot of red cells, but the serum is the same. What serum we have added here, the same serum will be added here only, but the cells are the fresh. Okay, the autoantibodies which are present in this part of the serum get attached to this aliquot of the red cells. Then the remaining autoantibodies we have put here for the second adsorption part. Same thing will be repeated here. It may be, I am showing you 3 parts here. It may be 4, 5 also. Like I told you, there may be 3 to 6 sets of cells to be used sometimes. What happened in this? You can see here. In initial sample, there is an autoantibody, a triangle. This is autoantibody, a triangle here. It's a coating patient cells and it's free in patient serum also. Okay. While allo-antibody, which is a square, is also present in serum. Now in absorption state, the patient cells have been treated to remove autoantibody. The treated cells are incubated with the patient serum. Now these treated cells are incubated with the patient serum. Now autoantibody from the serum begins to absorb on the patient cells. Okay, the autoantibody get absorbed on the patient cell. Well, the allo-antibody will not absorb. Okay, the allo-antibody will remain in the serum only. And last, when your absorption is complete, the autoantibody has been removed as absorption is complete. The adsorbed serum now have allo-antibody which can be easily identified by putting into the 11 cell panel. You put this serum on the 11 cell panel, okay, and you will get what type of allo-antibody it is. Now, there are some autoadsorption limitation. Like you don't have enough red cells, so many times not available. As patients mainly present here with severe anemia, like in our case only, our patient present with a hemoglobin of 3.9. I didn't get that much amount of the patient cells to do autoadsorption. Second, the allo-antibody also get absorbed when the patient was recently transfused. Luckily, our patient was not recently transfused, but of course we are not. But we are unlucky as we doesn't have enough red cells to go for autoadsorption. So what to do next? There's a next option available. It's called as homologous adsorption. What it is?
આમાં આપણે ચાલુ કરવું છે WhatsApp વેબ ખોલીને
Here the page.
Dr. Ravi, you are mute. We can't.
Now audible?
Yes, Dr. Ravi, go ahead.
Yeah. Now we have the third option. We have an allogenic adsorption is an alternative. I will explain you what in detail about the differential warm allogenic adsorption. I request you all to be attentive in this. It is little bit complicated. It is to understand what is differential warm allogenic adsorption, please. It's a principle. What is the principle of differential adsorption? What we see. See, I have taken everything from the ABB technical manual. For this method, the patient serum. Now we have a good amount of patient serum as patients are already anemic. If you get around 3 ml of the blood sample, EDTA sample, you have 2 ml or 2.5 ml of the serum only, or patient plasma or serum only. You have a good amount as the patient is already anemic. You divide the patient serum in 3 aliquots. Okay. Now you don't want a red cell of the patient. Now, what are the red cells here? The selection of red cell for allogenic adsorption. you have to identify 3 cells, like one is R1 R1, one is R2 R2, one is RR. You want the 3 cells from 3 different donors. You have to identify this thing. This following adsorption, we will do the adsorption with these 3 cells, and following adsorption, we will put the antibody identification panels are performed separately on each serum alicot, and the reactivities are compared to the revealed underlying allo antibodies. Now, how it is? See, we have to select three different disk cells, R1 R1, R2 R2, RR. Now, once you selected 3 cells, and depend on what treatment you are doing on these cells, you have to select another set of the cells also. Like when you're using untreated red cells, one of these 3 cells, like one of the R1 R1, R2 R2, RR should be negative for kid A or kid B, Cal, Duffy A, Duffy B, S, and small s. One should be negative. Either of one out of 3 should be negative for this. There should be a pattern like this. Okay. If you are using enzyme treated, if you are treating the cells, your cells R1, R1, R2, R2, RR cells you are using with treating with enzyme, then you should only type that for one of the 3 should be negative for kid A or kid B or Cal. When you're using ZAP, it should be negative. One of the 3 should be negative for kid A or kid B. Okay, why it is? While enzyme destroy your MNS like M and Duffy and S. Okay, so that's why we don't want, when you're using an enzyme, we don't want Duffy and S on this. When you're using ZAP, the ZAP also destroy your Cal also along with enzyme. Okay, it's a combination of DDT and enzyme only. ZAP, it will destroy your Cal also. That's why we want, if you're using ZAP treated red cells, we want one of these 3 cells, R1 R1, R2 R2 RR, should be negative for kid A and kid B. This is a combination I want. Okay, like this one. If you're using untreated cells like R1 R1, R2 R2 RR, what is R1 R1? R1 R means it is positive for D, it is positive for capital C, while negative for capital E, negative for small c, and positive for small e. Well, R2 R2 is opposite of this, except D plus is C negative, E positive, small c positive, small e negative. RR, here it is D, capital C, capital D negative, while small c and small e positive. One of this all, I want a negative in all of 3. You can see here, like here Cal is negative, but one of this cell is Cal positive, one of this cell is Seleno positive, one is negative. Similarly, Duffy A, one of this cell is Duffy A positive. Okay, one of this cell is Duffy B positive and negative also, and one of this cell is Kid A positive negative. One of the cell is kid B positive negative. Similarly for S. Okay. Now what's the principle? See, coming back. Now you have 3 serum aliquots and 3 different cells. Okay. We'll put similarly autoadsorption. Now here we are having the patient serum, and this is R1 R1 cells, patient serum RR cells, patient serum R2 R2 cells. We'll do adsorptions like this, and at last every time we want at least 30 minutes to 60 minutes incubation in between at 37 degrees Celsius. Okay, and at last we have the adsorbed plasma. Now we have 3 adsorbed plasma in last. One is R1 R1 adsorbed plasma, one is R2 R2 adsorbed plasma, one is RR adsorbed plasma. Okay, how it works? See, these are, okay, these are the cells. Now it's quite easy. See, the antigens which are present on the RBC, okay, corresponding antibody will be removed by adsorption. You can see the D antigen is present, the antibody, corresponding antibody is anti-D, will be removed by adsorption. It will not present in the serum, it will get adsorbed onto the red cell. Like in R2 R2, the D is present, of course the anti-D will adsorb. While in RR, the D is absent. Okay, this cause this way, okay, small c is present, the small c get adsorbed, and the antigen which is negative, the RBC which is negative for the antigen, the corresponding antibody will remain in the serum. I give an example. Suppose, for example, your patient serum contains capital C. This is the C positive is there. It will get absorbed by R1 R1. Okay, antibody absorbed by R1 R1. You will not get antibody in this. Capital C is negative in R2 R2. It will not get absorbed in R2 R2. It will remain in your serum, in your R2 R2 absorbed serum. If it is capital C in RR also, if C is negative capital C, it will not absorbed by the RR cells. It will remain in the absorbed RR serum. When you put a 11 cell panel with this 3, Here you will get negative, but here you will get a pattern of anti-C antibody which will confirm that it is anti-C. Now you should ask, where is the auto-antibody? Of course, auto-antibody will get absorbed in all the three. As we are doing multiple absorptions, and along with auto-antibody, the allo-antibody will also absorb. That's why we are using a pattern of the 3 cells, which an equal opportunity for every antibody to get absorbed also. In our cells, we have taken a pattern similarly, but unluckily we got S was not negative. Okay, S was positive in all. So I thought, okay, we will provide smallest negative patient blood to the patient, and Seleno was not possible. And of course, I was not expecting even Seleno. It's not possible to get. It is a high frequency antigen. This is a pattern what we have done. Antibody removed by absorption. Antibody will remain in the serum. What we have done the differential adsorption. We got an adsorbed plasma, 3 adsorbed plasma. One is R1R1, one is R2R2, one is small r. See what we have done. We have put an 11 cell ID identification with this adsorbed plasma. You can see the adsorbed plasma with R1R1. We got a pattern, but before going for a identification of antibody, I want here. I want what I have done. I want this R1R1. This is what is the antibody removed by adsorption. This all will be removed, and this will remain in the serum. I will focus on this antibodies only then. You can see what I got the reaction in this. Cell number 2 and 3 positive. Cell number 6, 7, 8, 9 positive, 10 negative, and 11 is positive. When you see capital E, it is not matching with this. I will go fast and come to a conclusion directly. You can see in the S, it is clearly matching. Cell number 2, 3, 6, 7, 8, 9, and 11. While your auto is negative now. Okay, as auto antibodies get absorbed fully, while allo antibody will remain in the serum, and it is matching. Your pattern is matching with S, and your pattern is also telling the S will remain in the serum. Now coming to second part, the adsorbed plasma R2R2. See, antibody get removed by adsorption. The S antibody will removed by the adsorption. Here you are negative, as the anti-S antibody got removed by the adsorption. It got attached to it got absorbed to the RBCs, the corresponding RBC, as S antigen was positive in R2R2. I'm getting back to the pattern what I have done to confirm. See, you can see here R2R2 capital S is positive. That's why in R2R2 adsorbed plasma we are not getting any picture. Like in RR, S is negative. We should get the picture in RR adsorbed plasma now. Okay. Here it is. In RR, we got a similar picture. It's confirmed that it is anti-S allo antibody, which was masked by auto-antibody. And auto-antibody is not negative here. Clear? The final results were anti-S allo antibody was identified, which was masked by auto-antibody in this patient. What we done? Patient responded. We started the patient with steroids and low dose of rituximab here as a low dose fixed dose of 100 mg per week for 4 weeks. And we have provided them 2 units of S negative ORH positive red cells. They are transfused. To conclude, take home message: diluting autoantibodies to detect alloantibodies is unreliable and should be strongly discouraged. I request you all not to follow this method, please. Least incompatible or a best match blood without alloantibody identification should be reserved only for urgent transfusion, emergency transfusion. Differential warm allogenic adsorption is a good option to resolve such complex cases if you have R1, R2, RR and all and R2, R2 cells ready available with you. If you find out these cells once in your month, it will be available. I think so. It's a whole bag will be available for you to solve these cases for 40 days, 40-50 days. It will be easy to perform any auto with alloantibody cases for solving any alloantibody cases with auto. Thank you.
Thank you so much, Ravi. It was quite a nice and elaborated talk on auto-adsorption and how to treat DAT samples. So now I request Dr. Shadiya Al Khan to present her case and her talk. And Dr. Shadiya, you can start sharing your screen.
Yeah.
Yes.
So, hello everybody. I'm Dr. Shadiya Al Khan from Oman. I would like to thank the Asian Association of Transfusion Medicine Immunohematology working group for organizing this webinar, and also thanks all the audience for attending this webinar. And I would like to share this interesting case of refractory severe warm autoimmune hemolytic anemia in a pregnant lady.
You have to tap on the screen once, then okay, go ahead.
So this is our patient is a 29 years old pregnant female. She's in her first trimester at 10 weeks of gestation. She presented to the local health center with excessive nausea and vomiting for 1 week, and that was followed by fever, fatigue, palpitation, and tiredness. That was for 3 days. Initially at the local health center, she was treated as a UTI for 3 days. However, after 3 days, her symptoms got worsened and she was referred to our hospital for further workup and management. Taking further history, she's actually a previously healthy lady with 2 previous normal pregnancies. She had COVID-19 infection 2 months back, and that was a mild infection. She did not require any hospital admission. She denied history of weight loss or appetite, urinary symptoms, respiratory symptoms this time, and she's not on any medications. On examination, she's pale, she's also jaundiced. She was tachycardic with a pulse of 140. She did not have any organomegaly, and her saturation was 100% at room air. So we did the initial investigations, including CBC, and she was severely anemic. Her hemoglobin was 3.7. The MCV was normal. Other cell lines like platelets and WBC counts were normal. Her hemolytic markers were raised. Her total bili was 89. Haptoglobin was undetectable. The LDH was more than 1,000, and her retics were still not raised. And on peripheral smear, she was having severe anemia with spherocytes. So the differential diagnosis of hemolysis in a pregnancy could be HELP syndrome, MAIHA with TTP or HUS, could be acute fatty liver of pregnancy, immune hemolytic anemia, which could be acquired, or it could be secondary, or it could be COVID-19 complication if she had the reinfection of this virus. So her liver enzymes and electrolytes were normal. The renal function is also normal. Coagulation profile was also within normal limits. The PCR for the SARS-CoV virus was undetected. So this time it was not there. No schistocytes were there on the peripheral smear. So that excluded some of our differential diagnoses. At this point of time, 4 units were requested from the blood bank. So this in the blood bank, her blood group is B, RHD positive. Our antibody screening panel, which includes 6 cells, it showed pan reaction. The antibody identification panel also showed pan reaction with LISS as well as enzyme treated cell. And if you see at the bottom of the slide, her autocontrol was also strongly positive. We did tube method at strict 37, thinking maybe these are cold autoantibodies and they may disappear with the pre-warm technique, but didn't happen. She continued to have the pan reaction across the panel. Further, the DAT was done and it was positive for IgG only. It was negative for complement activation. And doing her red cell phenotype, which was done after washing her red cell, she was R1 with KEL negative and some of the other antigens negative. So to provide her with blood, random cross match was done with RH and KEL match blood, but it was not helpful. We did not get any cross-match compatible units. At that point, we issued one RH and KEL match unit, which was cross-matching least incompatible. And we continued with further investigation. Initially, we did the elution, and the Eluate reacted with all the panel cells. We also did differential allo-adsorption. Auto-adsorption was not done because she was severely anemic. And differential allo-adsorption, when it was performed with phenotype mesh and enzyme-treated cells, we used R1, R2, and little r. She had, after second adsorption, all these autoantibodies were adsorbed, and there was no underlying allo-antibodies identified in her case. So our diagnosis at this point was she's having warm autoimmune hemolytic anemia with all the findings we had. So autoimmune hemolytic anemia is uncommon entity, although it is well known over, over a century, it is still continue to pose diagnostic, prognostic, and therapeutic dilemmas. This is because of significant difference in the rates of hemolysis and associated diseases, and because there is considerable clinical heterogeneity in these patients. The incidence is like 1 to 3 in every 100,000 annually, and warm autoimmune hemolytic anemia is the most common entity along comparing to the cold autoimmune hemolytic anemia. And the pathophysiology is basically these warm reactive IgG antibodies. They bind optimally to the antigen on red cells at 37 centigrade. These coated red cell destruction is happening basically by the Fc receptors, which are expressing the expressing macrophages primarily located in the spleen, and also partial phagocytosis results in the formation of spherocytes, which then get trapped in the spleen, which also results in enhanced red blood cell destruction. So in terms of the etiology, it could be primary, which is almost half of these cases, and secondary. Secondary causes of warm autoimmune hemolytic anemia could be lymphoproliferative disorders, most commonly B lymphomas like CLL and non-Hodgkin lymphoma, which is well known to cause this hemolytic anemia. Rheumatic disorders, non-lymphoid malignancies like ovarian tumors, chronic inflammatory diseases, and some of the drugs. So the progression of the events that need to be dealt with in the management of autoimmune hemolytic anemia includes using the appropriate methodologies for diagnosing autoimmune hemolytic anemia. And this will be mainly the investigations to rule out the underlying allo-antibodies, which are capable of causing hemolytic transfusion reaction. This is because there are literature saying that allo-antibodies are detected in almost 32% of the patients. And the case which was presented before this presentation by Dr. Ravi, where there was an allo-antibody underlying the autoantibodies. Also needs to consider the primary or the secondary causes, and then we need to choose the most effective treatment. Communication is a key to successful management in these cases, because we need to know the past transfusions, what urgency, how much urgent it is to provide the blood, and if patient has comorbidities. And life-saving transfusion should not be delayed if we because of the incompatible units. So coming back to our patient, she was transfused with 2 units of red cells, which were RH and KEL-match and cross-match compatible with the adsorbed serum this time, because we had the adsorbed serum. She was started on the same day on the IV methylprednisolone and also IVIG 1 gram per kg per day. However, across the day 4 of admission, she was given 5 units of red cells, but her hemoglobin was still not elevated, it was still 4. She continued hemolyzing with, which was evident on the hemolytic markers. This time we added rituximab, and she was also started on oral prednisone. Her other investigations came back by that time, including viral serology, autoimmune workup. The COVID PCR was repeated for her. That was also negative, and viral serology and autoimmune workup was negative. CT was not done because she was pregnant, and patient refused to do bone marrow examination. On day 5 of admission, because she still was having low hemoglobin, we azathioprine as an immunosuppressive agent was added, and also started on EPO. And on day 6 of admission, her repeat hemoglobin was still 3.5. So this time she was given more units, 3 more units of red cells, and fetal viability scan was done, from every 2 days, and by day 6 it was normal. Remember, she's at 10 weeks of gestation. By day 7, we started her with therapeutic plasma exchange because she was still not picking up her hemoglobin. And after the initiation of therapeutic plasma exchange, patient hemoglobin levels stabilized. They were between 6 and 7, and her hemolytic markers, although were raised, but they improved compared to the previous ones. So therapeutic plasma exchange is extracorporeal treatment where plasma gets separated from the cellular component. This separated plasma is then discarded to remove excess of substance. For example, in our case is autoantibodies, but it could be other substance like immune complexes, lipids, and also light chains, and that get replaced with either colloid or crystalloids. And between 1 to 1.5 plasma volumes are exchanged per session. And according to American Society of Apheresis guidelines, cold agglutinin disease is actually considered category 2 recommendation for using the TPE, because in cold agglutinin disease, it's mainly IgM antibodies and it's intravascular hemolysis. So it's more robust in treating the hemolysis with the TPEs, while IgG, pathogenic autoantibody, and significant extravascular hemolysis is considered category 3 recommendations for using TPE in these cases. So coming back to our case, now she is on day 8. On day 8, she unfortunately started to have PV bleeding, and she had actually incomplete miscarriage. So she went through dilatation and curettage. And giving you a glimpse of the autoimmune hemolytic anemia caused primarily by pregnancy is poorly described in the literature. And the cases which has been reported, they showed that mainly it happens, if it is induced by pregnancy, it mainly happens in the late pregnancy and responds well to the steroid therapy as well as transfusion, with slight or no hemolytic process happening in the newborn. However, it is less likely that this happens because of the pregnancy, because our patient had 2 previous normal pregnancy and she was very early in pregnancy, only at 10 weeks. So at day 9 of admission, we were able to do for her the CTs because now she is no longer pregnant. And on CT, although there was no evidence of malignancy, or pan-CT was done for her, but she had a thrombus developed. She was on DVT prophylaxis across the course of her admission, but she developed this small inferior vena cava thrombus and also a subsegmental pulmonary embolism. So the decision we made this time to start her on anticoagulation, and she was managed with enoxaparin and shifted to rivaroxaban for a total of 6 months because this was a provoked thrombus. So in summary, she received 25 units of red cells. She was with us in the hospital for 17 days. She was managed with almost all the modalities like plasma exchange, IVIG, methylpred, rituximab, azathioprine, EPO, as well as oral prednisone on discharge. And you can see this in the chart that, TPE, which was done on day 7, after that, her hemoglobin actually improved. And I think immunosuppressive agents also start picking up and treated the autoimmune hemolytic anemia. So on discharge, her hemoglobin was much better. It was 7.7, and her hemolytic markers were declining. And on follow-up after 3 months later, when we saw her in the daycare, she had normal hemoglobin, reticulocyte count were also normalized. And we tapered her steroids without recurrence of the hemolytic anemia till now. She's now, because this happened in August. So in conclusion, warm autoimmune hemolytic anemia is typically of IgG mediated, but it can also happen with complement. It is the most common form of the autoimmune hemolytic anemia, treated with steroids, immunosuppressive agents such as rituximab, azathioprine, IVIG, and severe cases, TPE can be used. Transfusion therapy can be difficult. Consultation with the blood bank is very important. And the final message is no patient with hemolytic anemia should succumb because of the serologically compatible red cells are not available. And by this, I will end my presentation.
Thank you so much, Dr. Shadiya. It was a very interesting talk and interesting case, and good to know how did you manage the case.
Yes.
So, mentioned the comments and questions we'll take at the end. So, may I request Sue Johnson now to share her slides and start her talk. So, we move ahead with for the third talk now. Your slides are visible, so you can go ahead.
All right, thank you very much. And I just turned my video on a minute just to say hi. I see so many friends that are on today. Thank you for joining. I'll stop the video now. So thank you, Dr. Ankit and the Asian Association of Transfusion Medicine for the opportunity to present one of my favorite subjects, a drug-induced immune hemolytic anemia case and investigation. So the case is an 83-year-old white male. He is in for a right shoulder wound. His hemoglobin at the time of the sample submission was 8.3, hematocrit of 25.9%, and he had been transfused 7 leukocyte-reduced red cells over the prior 2 weeks. The last transfusion was 5 days prior to the sample being drawn for the evaluation. This was the hospital pre-transfusion testing results. And you can see that the patient typed just fine as an O-RHD negative. And gel testing was done in the hospital setting. And you can see they had 2 positives and a negative result. We'll look more at that in a minute. And the other comment that we had from the hospital is that the serum plasma color was icteric. It didn't look good. Here's a result of the testing again at the hospital that was going to send the sample to the immunohematology reference lab. And you can see that the gel test, they did get some nice positive reactions and a couple of negative reactions. And if you look closely, you can see that the reactivity, the negative reactions are with the little e negative red cells, number 3 and number 7. The other interesting thing is that the autocontrol was 3+. When they tested it in a LISS test tube method, you could see all reactivity was gone, other than the autocontrol. So suspicious of maybe an anti-e. They went ahead and did the direct antiglobulin test, and you could see that it was, as all cases today, positive with polyspecific anti-human globulin and with anti-IgG. And the anti-complement was non-reactive. The interesting thing here was that they had done an Eluate, and it was negative as well. So just to summarize, the patients in O-RHD negative had been transfused 7 leukocyte-reduced red cells over the last 2 weeks. Hemoglobin right now is 8.3. It looks like there's an anti-e specificity in gel, but it's negative in a LISS test tube method. Now, anti-e is not so unusual, but the fact that the patient is Rh negative, the patient is most likely e positive. And they didn't share their typing results, but because of all the transfusions, it's difficult to do an accurate phenotype at that point. So they looked at that and they were really concerned about, well, what is this anti-e? Is it an allo-antibody? Is it an auto-antibody? And the more we know about the Rh blood group system, we have to always consider, could it be a partial e? And because the patient has a variant e, kind of like a partial D, and they made anti-e. But the DAT is also positive, which would maybe make you think it's more likely an autoantibody showing Rh specificity, and the Eluate was negative. At this point, they decided to send it to the IRL, to the immunohematology reference lab. And interestingly, the tests that they ordered were a red cell genotyping to get a good picture of the patient's probable phenotype because of the transfusions, and an antibody identification. And right from the requisition, please evaluate for possible anti-e. Again, because they saw the reactivity in gel, LISS was negative, is there really an anti-e there? So this is the testing from the IRL. And you can see we do a little bit additional testing. We always include anti-A, B, and A2 cells. But just confirmed with the hospital had seen that the patient looks like an O-RHD negative. And again, noting that the serum plasma looked kind of brownish yellow, icteric. Again, the direct antiglobulin test was confirmed, 4+ with IgG, complements are negative, control looks good. Now, in the reference lab, we'll always go right to test tube methods because we want to assess, is there reactivity at different phases? And you can see here that in a saline, no additive, there is no reactivity at immediate spin or at 37 degrees. So totally consistent with what we're seeing and what the hospital had seen really as far as reactivity. No indication of an IgM type antibody. And in the saline antiglobulin test, you can see this variable reactivity, the kind that most often the laboratory scientists don't like or anybody likes, but there's weak variable reactivity. And you're wondering what, does it show some specificity? Kind of, maybe. But when we did a PEG tube enhancement method, here we're seeing more similar to what the gel results from the hospital saw. And you can look closely and you can see that, again, number 3 and number 7 are literally negative, and they're negative in the PEG tube method. And again, the autocontrol is positive with all 3, or with all the methods we've been testing with. We also went ahead and tested it against Ficin treated red cells, enzyme protease, and you can see that the reactivity was enhanced. And now the little e negative cells were also coming up positive. So it looks like we have in anti-little e like or a relative anti-little e specificity, and probably thinking at this point autoantibody because the autocontrol is strongly positive and the DAT is positive. Selected cells were run just to ensure there's no other allo-antibodies present. All of these cells are little e negative, and we can do our evaluation and we can rule out the presence of all other allo-antibodies. We use a cross-out method where we will cross out directly on the panel anytime we have a single or double dose expression of the cells. Of course, we look to make sure we have good double dose homozygous rule outs whenever possible. But we could rule everything out except for that anti-little e-like antibody. Now, here's the interesting thing. The Eluate. So in the previous case, we've talked about the Eluate being positive, but here we have a beautifully negative Eluate. And when we see this, we really start to think about a possible drug-dependent antibody, especially with everything that we know so far about the patient. So that Eluate is negative, and the Eluate that this particular method is a rapid acid Eluate, and that's the one that's most commonly used in the US for sure. It comes in a nice kit format. Several manufacturers have that available. But a negative Eluate starts to make us think. Now, what do we know? We have a strong positive DAT due to IgG. The Eluate is negative, and it looks like it's an auto anti-little e with no underlying allo-antibodies. Now, we're thinking though, they asked us to evaluate to see what this anti-little e is. But one of the things we know, right, in our evaluation is the Eluate was negative. That's not consistent with an autoantibody or warm autoantibody. And we also know that many drugs can actually be associated with an antibody specificity. And if we're in particular looking, this slide just shows that there's a number of different drugs that will show, for example, Ladinaxef, I picked one I couldn't say very well, but anti-little e, okay? Piperacillin, anti-little e. This one in particular, very common that we see anti-little e specificity, Tolmentin, and a whole host of specificities. And this slide just looks at it a little bit differently. So there's a number of drugs that have been known to show anti-little e specificity in the serum. Piperacillin, Tolmentin, a whole host. Diclofenac will show relative little e. These are all the drugs that have been associated or reported to show some specificity in initial testing. And this is without any drug added to the test. But what we have to remember is that if the patient is still currently on the drug is in the test because the drug is present in the plasma. So we can actually see antibody specificity, and we can see even broad reactive antibody due to the drug. So it actually is a drug-dependent antibody that's reacting. So because they didn't order drug studies, they asked us to look at the antibody identification. We call the patient's physician to determine, is it okay if we go ahead and maybe think about drug studies? Because the serology really is pointing us to a drug-induced immune hemolytic anemia. And the fact that this patient was being transfused, we know that that was occurring. One of the disadvantages we have as being in a reference lab, we don't always get all the great clinical information that's been presented so far today, but we can, ask for it. We have to ask for it to get more information. So they said, yes, go for it. So of course, if we're going to do that, we're going to now look at what our normal evaluation would be. And we've actually got a lot of it done already. Before we had the approval to do the drug studies, we'll always do an ABO-RH type. We'll do a direct antiglobulin test. If a drug study had been requested and it was negative, then we would want to get more patients' clinical information to investigate, is this really due to a drug? If it's positive, like we have already done, we'll test with IgG and anti-IgG and anti-C3. We'll do our antibody detection tests, or screen and panels. We'll always test again in test tube methods. Saline, enzymes, and PEG is optional, but you can see we did all three things already. And then we do our elution. And if the Eluate had been strongly positive, we would have thought this is just an auto anti-E due to a warm autoantibody. But the fact that the elution was negative in this case made us think, oh, I wonder if this is actually a drug-induced hemolytic anemia case. And the other thing just to point out is that sometimes in cases of drug-induced immune hemolytic anemia, the Eluate can be weakly positive. We already heard Dr. Ravi talk about the fact that usually it's pan-reactive, strongly positive, like greater than 2+, usually 3 to 4+. And if it was only a 1+, I would still be suspicious. And then finally, before we actually begin any testing, we always want to make sure that there's signs and symptoms of hemolysis. And we also need to know if any serologic testing, or before we do any serologic testing, what's the patient's drug history? So we really need to get a very detailed investigation. So it could be prescription drugs, it can be over-the-counter drugs. And sometimes you really have to ask a lot of questions before you get the right drug. And some people have great records, some people don't. Some people take their spouse's medication and they don't want to tell you that. We've had all those scenarios. And the last thing is, it's super important we look at the timing and dosage of the drug, because drug-induced immune hemolytic anemia is not going to occur in a medication that has been a patient has been taking for 5 years. It's more of a mechanism where the patient has been exposed to the drug before, and then they take it again, and now there's a hemolytic process in most cases. So it's more like a transfusion reaction in a sense. So here's our patient's drug history. You can see the patient had been on aspirin, taking aspirin for a long time, Lipitor, just only for a week, I guess. The levodopa for about a week, Tylenol for almost a year, heparin in this hospitalization. And then piperacillin, tazobactam, or Zosyn was now about a week ago till present, and then Senna, which is an herb. So we look at this list, and what are we going to do, or how are we going to decide what to test for? Because we got the approval to do the drug studies. So we take a look at it, and the one drug that we know is notorious these days is the piperacillin tazobactam combination, or Zosyn, or piperacillin by itself. And the timing is absolutely right on. This is 11/22. The sample date is 12/4. Patient is still on the medication. So that drug is still present in the patient's circulation. And we know that this today is our #1 cause of drug-dependent antibodies that we see in our laboratory and others as well. So we have the drug we want to test for in looking at this history. All right, so we now know the drug, and sometimes we get a list of 2 pages of drugs, and so we'll go ahead and we'll look at all of that. And the places we like to go to see has this drug been reported are listed here. The methods in immunohematology and the ABB technical manual are actually the 2 that we'll go to first, because there's really nice charts of all the updated drugs and that have reasonable evidence of causing drug-induced immune hemolytic anemia. So when we know a drug has been reported, we'll go on to do our testing. If there's no documentation that a drug is suspected, we'll probably still do the testing, but we'll want to ensure that the timing is right and everything. Then we look at, well, what's the mechanism by which this drug is determined to cause drug-induced immune hemolytic anemia? And by mechanism, I mean, is the drug able to bind to the red cells tightly? And that then we are going to test with drug-treated red cells, or does the drug not bind to the red cell? And that would be using a procedure that we're going to test in the presence of drug. And if we don't know, or the drug hasn't been reported, it doesn't stop us, but we're probably going to use both procedures. And this is just an image, because whenever you hear talk about drug-induced immune hemolytic anemia, people like to talk about possible mechanisms. I don't really, because I mean, the only one that's really been reported is the drug, or confirmed as the drug adsorption, or hapten-dependent mechanism, and that is where the patient has an antibody to an epitope of the drug, and the drug can bind tightly to the red cell membrane. That would be classically the penicillins, high dose. Today it's the high dose penicillins, or piperacillins, or derivatives of penicillin for the most part. The autoantibody type is basically that the patient has been on the drug and they develop an autoantibody, and there's no actual drug testing that we can do. And this would be classically Eldamit or methyl-dopa, and the drugs that we know about that were famous for doing that. And then finally, this is the case where this blue structure is a case where the drug doesn't bind to the red cell membrane. We could mix red cells with that particular drug all day and nothing happens. And here, though, we're pretty sure that the drug alters an epitope on the red cell membrane so that the antibody can actually bind to an epitope on the red cell with the drug being present. And this used to be called the, in quotes, immune complex mechanism, but it doesn't even fit an immune complex, because the thought there was that an antigen and antibody would bind and then non-specifically sit on the red cell. We know that's not the case. And this is actually now, has been a little bit better described in the platelet world, but we really look at this now more as, how are we going to test? Does the drug coat the red cells or doesn't it? So in this particular case, we know that it's piperacillin or zosyn, the piperacillin and zosyn, and we know that we can test in the presence of the drug. And we could also actually test with drug-coated red cells, but it's much easier to just put the drug into solution to do the testing than trying to pre-treat the red cells with the drug. So we have to get the drug into solution, and we always ask for the actual drug from the patient or from the hospital that'll refer the sample. And sometimes we get tablets, capsules, powder is the best, or sometimes we get a solution, but we always try to dilute to a concentration of 1 milligram per mil. And that is the standard that we use for testing. And that 1 milligram per mil comes from Dr. George Garrity. And I talked to him one time about it, and he said, well, we thought that it would always be at around a therapeutic dose, or actually a little bit more. And that's where that number comes from. And then when we're going to test in the presence of drug, because so many of these drug-dependent antibodies do show some RH specificity, and we did some studies years ago, we will always use little e positive red cells in a saline suspension. We can test, usually we start with untreated red cells, and if we're really suspicious, we might also use enzyme-treated cells, but they're always little e positive. We add 2 drops of the patient's serum or eluate or control to the appropriate tubes, a drop of the little e positive red cells, and 2 drops of the drug solution. That's the testing. It's actually pretty straightforward. Then we do our testing. Now the ABB technical manual method says to incubate for 1 to 2 hours at 37, centrifuge read, wash, and add anti-IgG. We prefer the method, it's in the methods book. We incubate at room temperature for 30 minutes because then we can look to see, is there an IgM component to this drug-dependent antibody? Centrifuge read, then incubate it for 60 minutes at 37. Allow time for the antibody, the drug antibody to bind with the red cell. And then centrifuge and read, wash, and usually add polyspecific antihuman globulin. So this is the result of the testing on this particular patient. So we're very excited to see that the patient's serum plus Zosyn, using that method I just talked about, room temperature was negative, 60 minutes at 37 was negative, but when we got to the antiglobulin test was a nice 3+ reaction. The other thing we have to keep in mind is that we have to make sure that we run controls. So patient serum with the diluent was non-reactive. Remember that initial reactivity was easily diluted actually. So this is like a 1 to 2 dilution when we add the diluent, so you could see no reactivity. Normal serum plus Zosyn, non-reactive. Then we test the diluent plus the drug, all controls, and I'll go to the bottom. We always, whenever possible, test a positive control. You may not have that yet, but that shouldn't stop you, because if you do the testing, save the patient's serum or plasma in the freezer, and then you can use it for future testing. The particular drug, Zosyn-dependent antibody that we have actually reacts at it. This particular one is reactive at room temperature, but we had a nice 3+ reaction that assured that the drug's in solution, then that testing is accurate. Going back to the eluate, you know, in cases of where the drug antibody reacts in the presence of the drug, it's not surprising to see the eluate non-reactive when we add drug. I don't know if it's a function of the eluate that we perform, because it's this acid eluate that mixed with the drug. Not sure if the conformation is quite the same. So not a surprising result. But this tells us that we have a Zosyn-dependent antibody, which is clearly present here. Also remember that they originally wanted us to do a red cell genotyping panel, and you can see we do 44 antigens, this is just the list of all the different antigens that we type for. I mean, in particular, in this particular case, because of that anti-little e in the beginning, not knowing if it was auto or allo, we always include some mutations where we could identify partial big C, little c, and little e. And we also test for a number of low and high, mostly low prevalence antigens, again, in the RH system that would tell us if there's a partial antigen. And then we test for the routine antigens as well. So here's the patient's red cell genotype, absolutely normal RH phenotype, big C neg, big E neg, little c pos, little e pos, no indication of a variant little e. And everything else looks pretty standard. So the sample was referred with a request to identify an anti-little e and perform red cell genotyping. DAT was positive, auto anti-little e was identified, and because of what we know and that eluate being negative, the Zosyn-dependent antibody was detected when we tested in the presence of drug. And so our report indicated these serologic results are consistent with drug-induced immune hemolytic anemia due to Zosyn, and these results need to be correlated, of course, with the patient's clinical course and drug history. So just a little bit on drug-induced immune hemolytic anemia. It's rare. It's only reported to be 1 in a million people versus 1 in 100,000 or so. First reports go back to 1966, and it was penicillin. And then that's the one that we know binds to the red cell really well. Methyl-dopa was reported to cause autoimmune hemolytic anemia in the same year. Now there's greater than 140 drugs that have been reported with reasonable evidence. And one of the things just to note, these cases generally, if it's a true drug-induced hemolytic anemia, are pretty dramatic. You will see hemolysis. You will, I love this image that was shown back in 2010 by Toby. And you can just see 1 p.m., no problem. Patient starts ceftriaxone. By 9 p.m., that's the color of their serum. It looked horrible. And then they got him off the drug, but it took a couple days, and it wasn't until day 4. Now it's starting to clear, and by day 5, everything looks good again. Another thing just to note, for a while we were thinking the DAT might be weaker, but now we know, and this is from the most current edition of the technical manual, drug-dependent antibodies reacted with untreated red cells in the presence of drug. Again, this used to be the old immune complex mechanism, but now we know IgG and complement are detected, but complement may be the only protein present, but most of the time patients will have strong positive DATs due to IgG. As we talked about, the eluate will be negative, once in a while, weaker than what we would expect. And the other thing, just to focus on a little more, is that serum reactivity. If the drug is still present in the patient's circulation, the drug-dependent antibody can actually cause a positive reaction, like we saw in this case. It looked like an anti-e. And now we know, right, that drug-dependent antibodies can show some blood group specificity. And just to show you that it can occur in any method that we use. So if we just look at this result, right, if the typical serologic findings are positive DAT with IgG, sometimes complement, antibody reactive in the serum, I mean, it really could look like a warm auto, but remember, it could be drug-induced hemolytic anemia as well, especially when that eluate is negative. So the eluate is negative, it's a drug, it's positive, it's a warm auto. In the serum, the drug-dependent antibody will disappear within days if the drug is discontinued, literally within days. A warm auto antibody does not go away that fast. We all wish it did, but it doesn't. It can show up like this way. It could show up where there's only complement on the cells and there's antibody reactivity, an IgM type antibody reactive, and you might consider that as a cold, but remember, it could be a drug-induced case as well. Unlikely, in all the cases that we look at, we've only seen a handful that look like this, but it's possible. Again, piperacillin is the most common cause of drug-induced immune hemolytic anemia today, found either a patient receiving high-dose piperacillin IV or in Zosyn, and we test in the presence of drug. The other drug that's super common today is ceftriaxone. That's also a common cause in children. It's really a dramatic hemolytic anemia, and it's reported to be about 50% fatal. So, and I think it's mostly because it's not recognized. They've had previous exposure to the drug, and again, we'll test in the presence of drug like this case. Treatment, stop the drug. Get the patient off the drug. We monitor vital signs, urine output, renal function because of the hemolysis. I know patients might require intensive care. Some require temporary dialysis because of the severity of the hemolysis. And about half require transfusion, like our patient. Benefit of steroids is really unclear. We know people will give it, but we don't know if it really helps that much. So just to summarize, that detailed drug history cannot be overemphasized. It can result in severe life-threatening anemia. DAT is strongly positive in most cases with IgG and complement. Cases should not be confused with warm autos, cold autos, or delayed transfusion reactions. In this case, we're thinking of a transfusion reaction. Eluate is key for the serologic interpretation, and there's a lot of drugs that are responsible, but we always say start with the obvious ones. If you're interested, there's a nice case called dark colored urine on B-Learning on the Versity website, which I have it spelled wrong. It's VERSITI.org. We also have some great case studies on the Indian Initiative website as well. And here's my list of references. And with that, I thank you. I know this is the very end. Welcome questions.
Thank you so much, Sue. It was a nice case on drug-induced hemolytic anemia. Anybody who has any question, now you can unmute yourself and ask your question.
So there are some questions in the chat box.
You want to read out, Rafi?
Yeah, I'll go ahead. The first question is, for auto-adsorption, we'll use eluted red cells or normal cells for elution. Which method is preferred? I think it's to Dr. Ravi.
Rafi, I can't see the chat as I lost my connection. All chat box is empty now. What's the question? Can you please repeat?
It's from Dr. Divjot Singh Lamba. If he's around, he can just unmute himself and say, or the thing which he has typed is, for auto-adsorption, eluted red cells or normal cells.
It's normal cells we use. These are treated cells we use. We use enzyme treated or ZAP treated cells we use, not the treated cells.
And for elution, which method is preferred?
It's an acid elution is preferred.
Okay. The next question was from Deepak Jyoti. In case of autoantibody, can we do auto-absorption if there is mixed field in CAT, in column agglutination?
Of course, it is an autoantibodies are positive. You can go for auto-adsorption, but limitation of auto-adsorption are only two. One is the enough amount of red cells you need for auto-adsorption, and the second is that there should be a no transfusion history. Otherwise, the allo-antibody will also get absorbed as the transfused cells will be there.
Next question is, for auto-adsorption procedure, harvesting into new batch of red cells means, does the new batch of cells of patient needs to be treated as well?
See, what you've done, for example, if you're going for auto-adsorption, you should take around 4 to 5 ml of the packed red cells, treat that 4 to 5 ml, and make an aliquot of 1 ml. Okay, like this you can do an auto-adsorption. It's not an every time you need to treat fresh cells. You can treat around 4 ml or 3 ml or 4 ml of cells directly, and you can aliquot it for auto-adsorptions.
Okay. Next question, Corey, is it necessary to recheck the adsorbed plasma whether the adsorption was effective or not?
Yes, of course.
Okay. From Dr. Divjot again, why it can't be E plus S? Question.
E is a possibility. I have not included in my presentation actually. We have done a select cell. We have used the select cell also for ruling out the E and S, and it was identified as only. I have not included in my presentation. It's already lengthy. That's why.
Okay. Dr. Soumya has asked, DAT was positive. Can we tell the phenotype as valid?
No. If that is positive, you can't do any phenotyping is valid.
Dr. Shering has asked, why do LISS tube method when gel method is performed?
This question is to, I think so, somebody.
Yeah.
So the question was, why do LISS tube method when gel is performed?
Yeah, that was the one which was typed.
Sure. Okay. So we'll do that because we want to get a sense of, sometimes there's gel dependent antibodies that that'll be reactive only in a gel test tube method. So the LISS is just another look at that particular antibody, and just to ensure that the reactivity is not just due to the gel itself. And in a reference laboratory setting, we want to do that additional different testing to really get a good sense of what how that particular antibody reacts serologically.
So, Dr. Ravi, from Raya Ali, there's one question. What is the importance of knowing
Yeah, I can see this question. What is the importance of knowing IgG subclass?
Yes,
See,
yes.
I already covered in my presentation. See, IgG subclass are 4 types, 1, 2, 3, and 4. If you get in 3, it has been seen in 3 and 1 having a bad prognosis comparatively 2 and 4. If you're getting in 3 and 4, you can tell your clinician, sir, it is going to be potent hemolysis being going to be happen in your patient. Be ready with the high dose of steroids or a second choice of drug for the instead of, so you can go directly to rituximab also. It will help you in prognosis of patient. Nothing, it's not help you in diagnosis, it will help in prognosis.
Anyone wants to unmute and ask? Dr. Divjot Lamba?
There are 3 or 4
I just want to know, to Ravi, it's a nice presentation, but I just want to know with acid elution, the cells would not be there for autoabsorption, I think.
That's the problem, Divjo. That's why we are using directly what I am practicing here. I am practicing for adsorption studies, for autoantibody studies. We do directly for the differential. As in differential, I'm having a donor cell. There's no problem of patient cells then. That's why I don't prefer autoabsorption. There are multiple, as I told you, there are 2 main problems with autoabsorption. One is the availability of cells, one is the transfusion history. When the patient is presenting with you with a low hemoglobin, there's always a transfusion history is there. And they will restrict you for doing autoabsorption. And that time, their differential warm allogenic adsorption will help you.
So we don't need to do the autoabsorption.
You should not do. Why to wait? We can go directly for a warm allogenic adsorption.
With the auto and allo both.
Yeah.
Yeah, agree. And I think we always will try to do that elution because, you know, we know about the drug dependent antibodies, and we'll try to save a little bit of the red cells to do that elution method, right? Because even if we're going to we start with the allo-adsorptions or start with the adsorptions first, but then always try to save a little bit of red cells, because you can do an acid eluate with as little as 10 drops, 6 drops of red cells, and still get an accurate eluate result. So, yep.
There's a query to Dr. Sue from Devapriya Basu. The question is, if DAT is 2+ and Eluate is negative, then how can we suspect drug-induced hemolytic anemia? Because as
Good
DAT
question.
is 2+, Eluate can be negative for warm autoimmune AIHA also. I think you had clarified at the end of the slide.
Yeah, it's possible. It's always the key thing there is to evaluate the patient's medication history, the drug history. We do know, right, that there are patients that have 2+ or 3+ positive DATs and the eluate will be negative. But if there's no clinical history or the patient isn't on a medication that would induce an allo-antibody like that, then we would say, you know, we would just basically look at the history and see if it's been associated. And in this particular case, once we got more information about the patient and the fact that they're getting all these red cell transfusions for no other indication, and the drug history was perfect as far as when we tested the sample, all those things go together to decide to do the drug testing.
The next question
Great
is,
question.
can DAT reactivity vary with different manufacturers? And supporting question is, can DAT become negative if on steroids? From Manju, Dr. Manju.
Well, I'll answer that definitely they will. It can vary between manufacturers. You know, and I know that, for example, gel, sometimes we use gel, and when we're evaluating our patients for the super coombs or the DAT negative evaluations where they're negative by routine, gel never really is that sensitive. And it's the tube test actually for us is usually a little bit more sensitive, but they're pretty standard, not a lot of variation between the different methods. And the anti-hemoglobulin reagents too are characterized pretty standardly. So there's not a lot of variation.
Okay.
And then I guess the other question was, can the DAT become negative?
Yes, on steroid. Yeah, that question.
All right. So we don't
Okay.
usually get to see them at that point because they're getting better. Dr. Ravi?
Yeah.
There's a question to Dr. Shadiya from Dr. Deepti Sachin. Can it be COVID-19 associated AIHA if patient had history of COVID-19, as many reports are coming up?
Yes, thank you for the question. Yes, it could be, as it is in the literature that, with the COVID-19 infection, the autoimmune hemolytic anemia can happen. And most of the recent reports which are coming in the literature, they are describing the autoimmune hemolytic anemia infection happening during the infection itself. And the median age in one of the case series studies was like 9 days after the COVID infection. Patients developed the autoimmune hemolytic anemia, and some of them were warm and some of them were cold. So that's why, we did for this patient as well, this autoimmune the COVID PCR, just to make sure that it was not the cause. Yeah.
Continuation to that, was APLA lupus anticoagulant rolled out in this case?
Antiphospholipid antibodies, I'm not sure if it was done for her. I think yes, because since she developed the thrombus, it would have been done for her, but I don't remember the investigation now.
Okay. If any other attendees have any queries, you can just raise your hand or you can put in the chat box. Ankit sir, there is no more in the chat box or...
Okay, so thank you so much, Rafi. Rafi was the one who actually did the whole background work, conducting the whole program of this webinar. So with this, I first of all thanks all the speakers, Dr. Ravi, Dr. Shadiya, and Sue. Thank you so much for joining. Sue, I know it's a early morning for you. Thank you so much for joining. And with this. Great. Thank you so much. Thank you for attending this webinar from across the world, across Asia. There are people from Middle East, India, South Asian, various South Asian countries. So thank you so much. And a small announcement, we have one more webinar on cellular therapies this Saturday in the evening. If you don't have link with you, you can ask your ATM country representative. He or she will be able to provide the link for the webinar on Saturday. So with this, thanks again for joining. Have a good day. Have a great evening. Thank you so much. And with this, and the recording of this program also will be available. If you want, you can contact us. Thanks again. Thank you.
Thank you.
With this, I just end it here now.
Thank you.
Okay, thank you.
Thank you.
Thank you.
Thank you.